Okay, so our case presentation for today, we will start with this case of 3-year-old child presented with visual impairment. Okay, يلا دكتورة شيرين start. صوت.
MRI of the brain.
Okay.
This is T2
Okay.
axial sequence that is showing an abnormal signal intensity.
So T2 axial brain MRI showing abnormal signal intensity where?
Within the left orbital globe.
Within the left globe, okay.
It is low signal intensity T2.
Hypo on T2, okay.
Also there are some signal voids.
Some signal
and low
void.
signal intensity with other high signal intensity.
So it's heterogeneously.
It's heterogeneous, but mainly hypo.
Okay.
Mostly hypo.
I would say ISO, but no problem. ISO hypo doesn't matter that much. Okay. هذا ال T2. Any other findings قبل before we shift to other?
We should see the optic nerve.
طبعا this is under sedation. He's 3 years old. Okay.
The brain is normal, no space of blind region.
So nothing else significant, let's say. زين. راوينا other sequences. Let's see other sequences. So this is what?
This is T2 coronal.
T2 coronal flare. Okay? Showing the lesion that appears also ISO to hypo intense. So it added nothing to our to what we already have. What about T1? Let's see T1. Always take the second one because the second one is usually وين راح؟ the filtered image, usually the second sequence. Anyway, so on the T1 it appears what? ISO intense, exactly. What else should we look for when we see this kind of lesion? What are the important negatives to comment on?
The optic nerve is intact.
First, the optic nerve appears intact.
Yes, the lens also.
Well, okay.
Not occupied by the mass. With brain normal, no space of blind
Brain
region.
looks normal, intracranial compartment looks normal, optic nerves look intact, other globe looks normal,
Yes.
no signs of extension outside the globe, no signs of invasion to other structures. These are all very important negatives. مو بس positive, we have some important negatives regarding this particular case. Okay. What? Exactly. We should look for other lesions. Intracranial looks normal. So, what would you do next?
Next, we will go to the stare and contrast.
Contrast. You give contrast. Okay. Let's see if there is any contrast. These are. Try just a second. Wait. Let's see this one. The child is moving here, so you see the image is blurry. Let's see this one. You can adjust the window wheel. Just press on the wheel and you can make it lighter or darker. No, press and move. Wheel. شيرين. الويل. Press it. الشرخ. Press. Move. Okay. تمام. This is the mass or the lesion. Does it enhance?
Slightly, yeah.
Slightly. What about the coronal? Let's see the coronal.
The extraocular muscles are also normal.
We said there is no extraocular extension or invasion to other structures. It's entirely intraocular. Okay, so let's see some other sequences. Maybe we see something a little bit more in, because you know under sedation it's not that easy to image a child. Here, the same thing. It's mild enhancement, nothing significant. What about, let's see, this one here? This is even better. Focused on the orbits. Here, it shows some enhancement. Okay? Not delay, it's just the first two sequences the child moved, so they repeated the image after increasing his sedation. So, now, what would you like to do? If this child was in your clinic and he's sedated, he's in the machine, that's it? You say to the anesthetist it's finished, or you would like to do something else? Okay, diffusion and ADC, what else? Let's see, is there any diffusion? I don't think there is any diffusion here. Stir, we have stir. What else would you like to do? Something that helps in your diagnosis. What's your differential diagnosis for this case?
I saw some signal void with the magnet, so I will put hemangioma.
Hemangioma, okay.
But there is no intense enhancement.
Okay.
Should be intensely enhanced.
Should be intensely enhanced, okay. What else?
But most common in this age is hemangioma.
Is hemangioma. Okay. Rehan, what do you think?
Retinoblastoma. I would recommend CT.
You recommend CT scan because it's in this age, retinoblastoma is number one until proven otherwise. Okay? 3 years old child, you have to think of retinoblastoma till proven otherwise. You do CT scan to look for calcification, which indicates.
Retinoblastoma.
What about doing an ultrasound? Won't you do an ultrasound to see if this mass vascular or not? Make a little Doppler study. Especially that he is sedated already. You just take him to the ultrasound, put the probe, take it up and down, see if there is any vascularity within the mass. Is it bleeding, for example? It could be some sort of retinal hemorrhage. For example, I'm just saying. You can. It depends on the age of the blood, okay? And what about looking at the patient's eye? You see, is there leukocoria or not? First of all, the child had very obvious leukocoria. His eye was totally white, the pupillary reflex, okay? On the ultrasound, he had a mass with some internal vascularity. So it's not, for example, a cyst or bleeding or abscess or whatever, okay? It is a soft tissue mass. In this case, it is definitely retinoblastoma. Whether you do CT or not, it's just will be complementary, okay? So, if this case is a retinoblastoma, what else would you look for? Other eye, to look for bilateral retinoblastoma. And what else? Cella torsica, to look for trilateral retinoblastoma, okay? You'd never say hemangioma in a 3 years old. That's a fatal mistake. Age. We are clinicians. We are not photographers. We need clinical data. Your first clinical data, in any case, is the age and the sex. Is it a boy or a girl? Is it a child, adolescent, adult, elderly? Each age group has its own spectrum of differential diagnosis. Okay?
They will be dry on T2.
First, second, enhancement. Third, always common is common, rare is rare. 3 years old, eye lesion, retinoblastoma, number 1. Number 2, retinoblastoma. Number 3, retinoblastoma. Number 4, whatever you like.
The other differentials primary vitreous.
Could be if he is presented since birth.
Yeah.
This will be primary vitreous, okay? But if this is since birth, 3 years old recent, يعني impaired eye, let's say, this is a new lesion, not congenital. Okay? Good job. Older than this. ايش قد older? Like what? Adult. What would you think the differential diagnosis would be? Melanoma if it's hyper intense on T1. Can be a melanotic, which is much rarer, a melanotic melanoma. You put metastasis, of course, in the differential, and then you put other lesions like hemangioma and things like that.
The others, they are meningeal.
Yeah, and then you put the other like hemangioma and things like that. Okay. طبعا if you have a primary, you think of metastasis. If you have primary elsewhere, a whole long other differential diagnosis. Extraconal in this age group, or intraconal in this age group. It's a very whole other story. Okay. So, يلا منو next. خلينا نشوف. Nice case. هاي الريحان. هذه which one? It's simple but needs يعني شو نقول attention. والله simple. And interesting. Really interesting. يعني I don't think you'll see it again. And it's recent case, not that firm. This is a 16-year-old patient, and I'll give you just this history. You will figure out 16. Okay. Let's see what is going on. Pelvis MRI. I really don't know. You have a lot of sequences. You can just go through them. So, help your colleagues here. What is the sequence? T2, fat saturated, axial images of the pelvis. See other sequences, just not the T2. There we have a lot of things to judge by. Bowel. شوف عندك كورونا وعندك ساجيتال وعندك T1 وعندك T2 كل شيء. عليكم السلام ورحمة الله. Sorry? Infantile uterus, okay. Small size. What about the vagina? Is it present or not?
This is cervix.
Let me help you a little bit. Let's see this one. What's going on here? Yeah. What else? The vagina is present or not? And please, no one comment, okay?
I think the end is here.
Okay. And what about the ovaries? See, go to axial images, maybe help you a little bit. Or corona, whatever you like. So first of all, we have a small sized uterus, right? Alaykum assalam.
This
Sorry?
structure.
It's a vagina. So maybe rudimentary vagina, maybe open to the skin. You have any clinical examination of the perineum will be helpful in that. But
High for vagina.
but the thing is,
We are here.
okay, let's first of all, let's go to the corona. Is there ovary or not? Since we said it's small sized uterus.
I cannot see over here. No, over here. Might be this syndrome,
Rokitansky?
yeah.
Okay. But till now, you didn't find the most important and the most obvious abnormality. It's very big, very obvious, right in front of your face. And that's the very funny thing about this case. Let me help you, please. Let's see, what's this? Now, this image has all what you need to know. Or this sequence, I mean, not this image.
This is normal. Sure.
This is rectum, bowel, yes, okay.
And there, this is bladder.
You need help?
They have both.
Yeah. First, the very nice thing you did, first thing you asked, is he a male? And I told you, I really don't know. Is he a male or a female? Because he has uterus, he has penis, okay? And fully formed uterus, even endometrium is there. Okay? He has small but fully formed. And he has a vagina which might be rudimentary, I don't know. And if you look carefully,
Vagina here, because I think
rudimentary,
here.
yeah, rudimentary, okay? And I think there is some sort of an ovary.
I saw that one. I think it's not vagina.
Let's-
It's seminal vesicle. That's why
Could
I
be,
asked it.
could be.
Axial uterus.
Just a second, wait. Let's see this one. What's going on?
And this was this first presentation.
No, he's not a case, but just for confirmation, is there, should be he changed for a male or should he change for a female? And unfortunately, it was 16 years old, so he's too old to
Externally.
externally male. Or they raised him as a male, let's say.
تيجي بالعافية.
شوف يعني ده. No idea والله. I don't know. So he's literally 2 in 1.
I saw seminal vesicle.
There's no testicle because it's either atrophied or its ovaries atrophied.
What is this?
I think it's just either seminal vesicles or rudimentary vaginal.
Vesicle. I
Could be. You don't know. You can never be sure,
nice case.
right? It's very simple, very obvious, but you don't think about it. And it's once in a lifetime. اوكي يلا هل من منازل؟ خلينا نشوف ايش عندنا كيسز بعد. Yalla, we have a nice case, kind of typical or very interesting. Anyone interested in gynae? ها ماكو interested in gynae؟ اللي خاتل ورد. انت تعال. عبالك ما اشوفك. زين 219. وقف ايمان دقيقة. This case pathologically proven, يعني histopathology, let's say. Okay? This is a 20-year-old female patient presented with pelvic mass. Ultrasound shows cyst. No, go to this one. Yeah, this is what? T2 corona.
This is uterus.
Okay.
This is bladder. This is ovary.
Okay.
This is ovary, and this is
Where is the other ovary? دقيقة.
Yes.
The right ovary, where is it?
Checking for it. Sorry.
If you like, you can see other sequence. Just wait a second, because there are multiple. We did it several times to get a good image of that. Let's see this one.
The same. It is T2, no facet, and this is uterus, and this is ovary.
Mm-hmm.
The other ovary still I cannot see.
Okay. Where is the pelvic mass that they are
They are searching for.
search or they saw in the ultrasound?
What is this?
Wait.
It's in front of me.
Just a second. Wait. You can just look here, and you can
Yes.
make it smaller. Yeah. Where is the mass?
This is the mass. Abdominal. This is hypointense mass.
Hypo?
Sorry, hyperintense.
Okay.
Well-defined, well-capsulated intra-abdominal mass.
Huge mass.
Huge mass.
From the pelvis to the liver.
Seems to be 12
20.
by 13 centimeter.
Well, I would argue more, but okay, no problem.
Homogeneous.
Homogeneous.
No.
What are these lines? High lines.
These artifacts.
This is artifact. Exactly. What kind of artifact?
Motion.
Breathing. Motion.
Yes.
Exactly.
Yes.
Tamam. Good. Till now we are doing well. So there is.
I'm thinking of first of all benign lesions like.
Wait.
Okay.
Don't think now.
Okay.
You have
Check
a
other
ton of
lesions.
sequences.
Yes.
Don't think from the first
Yes.
one. You will be mistaken. See everything you have.
B1.
Where's the one?
This انزلي دقيقة أو في الماوس.
This is
هذا
the one.
هذا تيو. يلا.
Also the same thing. There's the hypointense mass, cystic lesion,
Mhm.
well defined, it, located at the anterior abdominal wall or intra-abdominal.
Intra-abdominal, not anterior abdominal
Yes.
wall. Okay.
It's extending from the left kidney, I think.
Wait, don't be.
The origin of the lesion. Or
This is the thing.
yes.
From where
From
is it
where?
arising?
Yes.
This is the question.
Yes.
That will solve the whole thing. From where?
Yes. I'm thinking there is from the left hypochondrial region coming down upon the most of the anterior abdominal wall.
Don't say anterior abdominal wall.
Yeah, intra-abdominal.
Abdomen. Anterior abdominal wall means
Yes.
rectus sheath and things like that.
Yes.
Okay.
But then on purpose.
What about other sequence?
So,
I
yeah.
want to see?
انزلي بعد. Let's see other sequences. This is sagittal.
Okay. Sagittal T2.
Okay, good. شوية بالأذر ما صغري الصورة. Zoom in.
Slowly.
Click.
Okay.
No, the other.
Uh-huh.
Okay. عافية.
This is the muscles and the mass arising. This mass, it is from the pelvic region.
So it's not from the kidney.
Yes.
It's from the pelvic.
Yes, this is urinary bladder and this is the mass.
Where is the bladder?
This is.
Scroll.
No, this is.
The bladder is way down
This
here.
Yes.
Here. This is
This is. Yes.
So it's in contact with the uterus.
Yes. Not in contact. This is there is a wall.
رتعي بالother image شوفي
Yeah,
هسه.
contact,
No, it's in
yes.
contact with the
Yes.
uterus. However, it does not look like arising from the uterus,
Yes.
and we don't have such big mass cystic
Close
lesions.
side, it means not arising from
Okay.
it. Yes.
Then it's unilocular. It's
Yes.
cyst.
Yes.
Then do we have any contrast? Let's see.
Yes.
I'm not sure whether we have. This is T1 fat saturated.
Yes.
Goes هذا post contrast طبعا.
T1 fat cell, post contrast,
Any enhancing?
no any enhancement, subtle even in the wall.
Okay. CT1 without fat sat we have here. This one.
This is T1 fat cell.
No fat sat. Just T1
fat
post
cell,
contrast.
Yes, exactly. The same shadow or lesion till now I'm seeing all sequence, no any change.
Okay. Good.
So
So
this
question is, from where is it arising?
from it's intra-abdominal, from bowel, maybe mesenteric cyst.
You said pelvic. قبل شوي قلتي
Yes.
pelvis.
Where? It's not from uterus.
It's you tell me. I don't know.
Go down. Here.
Here.
No. Here, yes.
زين. Let's wait. Let me help you. Let me help you. Was this just zoom?
22-year female patient, and this by this with this huge cystic lesion, abdominal, and thinking first of the benign lesion like mesenteric cyst if it is intra-abdominal. That's about
What do you
30.
think of that?
This is maybe blood.
This lesion. What's this?
Ovaries.
This is an ovary.
Yes.
And
It's originated from the ovary.
so it could be. You said mesenteric cyst
Cyst or could be ovarian cyst,
or ovarian cyst.
chronic non-complicated ovarian cyst.
Okay. Or
Or maybe I am asking in the history of the patient if she gets menarche, first menarche or not.
she's 20 years old. She had a lot of.
If she has
Menstrual cycles.
She have been seen any normal hair cycle, usual cycle.
Yes, all
Maybe
cycle
I'm
is
thinking
normal.
for the hematocolpus, although the sequence is not
No,
good
the
for
uterus.
hematocolpus.
The uterus is
It's a
good.
cystic lesion.
We've seen the uterus is good.
Yes, uterus are good.
So
Yes.
خلينا نجي واحد. mesenteric cyst could it be يا شباب?
Why not?
Could be, why not?
Why not? تمام. I agree, totally agree. It could be a mesenteric cyst and coming down. So the question is from where is it arising? If, let's say if it's arising from the abdomen going to the pelvis, could be mesenteric cyst, could be what else? From abdomen down. Lymphangioma will not be unilocular. Could it be hydatid?
Yes. That's
Anywhere cyst can be hydatid. Okay. What else? Renal cyst, simple renal cyst. Maybe. I'm not very exact. Now, lymphocyte, طبعا of course, could be. What? Sorry. Urinoma if there is a history of renal injury or things like that. However, there is none. What about if it's from the pelvis going up? What could it be? Cystadenoma, ovarian cyst, exactly, chronic non-functional follicle or things like that. Then, what do you think this was? This is ovarian cystadenoma. Yep, huge ovarian cystadenoma in a 20-year-old female patient. Post-op.
We should comment that
Cirrus.
because they are different.
It was cirrus ovarian
There is
cystadenoma.
no papillary projection, no solid mass.
Of course, no malignant features. If there is ascites or papillary projections or post-contrast enhancement, all يعني goes in the favor of malignant lesion. His size is, of course, it was cirrus cystadenoma, ovarian cirrus cystadenoma. Yeah. Post-op. Huh? Right ovary, exactly.
We just put it on the corona.
Corona. This is corona.
Yeah. This is close line, I think.
دقيقة لحظة. Sorry, what happened? Just a second. You can see here, this looks like an ovary, and it is in part
Here.
going like to the
This one.
cyst. Yeah.
Yes,
Last
this
time.
Okay. So it's a nice case.
nice.
This case susceptible for torsion.
طبعا well, at this huge size, I don't think it will be susceptible to torsion because the whole cyst has to, rotate. If it should be smaller cyst to be susceptible to torsion. ما يتحرك شو يتحرك. Okay.
Thank you very much.
ويلكم. زين خلينا نشوف منو بعد. مو انا حسب هاي راح نشوف الكيس. الله يساعدهم. فرموا. زين خلينا نشوف. يلا ايزي 1. 205 خطأ ما صعب.
الواحد يجي على هذا
اي والله كلها تيبيكال يعني يعني اكثر من هاي ماس شو اجيب لك بعد.
لا يعني واحد يكون كان احسن.
اي يعني ودنا احسن يعني.
اي منها تنطلق القريحه بس هنا زين ستريت يعني المفروض ستريت فورورد ما ادري بعد. This is a 26-year-old male patient presented with wrist pain. يمك الماوس مستيرن سوق.
بس باي وين
Good. I have no X-ray, but you have to ask about an X-ray. Exactly. That's very nice. I like it. Whenever you see a wrist MRI or a CT scan, you first go for the coronal, and then you see if you need axial or sagittal or whatever. This is a survey. Leave it. وخري Turkey الماوس دقيقة. Let's see this T2 fat saturated coronal.
كرونيك سبين يعني
Few months, let's say.
شوية خلاص.
دقيقة أنا سويت شيء.
دكتور اني كرونيك ديزيز
No. Just a second. Wait.
اني هيستوري تروما
I don't know. ما أعرف والله ما شفته. يعني ما شفته in person.
بس يعني انا اشوف راح اساله يعني هيستوري
Okay ماشي أنا I'll tell you what I know يعني I don't tell you what I don't know. Salt. There is what?
هاي سيجنال انتنسيتي
High T2 signal intensity, the scaphoid and lunate.
نو اوبفيوس
دقيقة هسه خلينا نتفاهم. وين السكافويد؟ وين اللونيت؟ وشنو اللي بصفه هذا؟ What's this? Which one is that?
يعني
ترايكويتروم. وهذا شنو؟ تركي الماوس. هذا شنو؟
بس لحظة خلي أكمل.
لا بس لحظة. That's all I want. Just show me the bones of the wrist. سهلة. مال الاناتومي مال تذكرين بالاول كلية اعطونا اياها. إيه. زين اوقفي. دقيقة. ساعدك. اعطينا مجال. Anatomy is better seen on what? on T1 عافية هذا ال T1 يلا راويني
سكافويد.
سكافويد على جهة الألنا
لا عفوا هذا الراديوس.
هذا شنو؟ يلا عدي لنا البونز
سكافويد.
اوكي
يونت. ترانكويترام. فورمال سين.
اوكي زين دقيقة قلتي هذا سكافويد
يس.
وهذا لونيت
يس.
وهذا شنو اللي بالنص قاعد؟
جاب بتوين
قاعد زين خلينا نجي على نحطهم سايد باي سايد اجي وياك هذا التي 2 والتي 1 هذا جاب
no, this is the scaphoid.
اوكي
Unit.
اوكي
Small triangular shape.
امم
And triangular.
امم وهذا شنو؟ ها؟ هسه هذا سكافويد هذا شنو؟ صبروا يا شباب ها
Okay, part of it could be or could be unit.
اور كود بي لونيت وهذا شنو يعني؟ مصرة
Unit triangular. So this is a part of scaphoid.
بعد مساعدات جتي من الخطوط الخلفية زين
هم قاعدين بمكان.
دقيقة بسيطة خلينا نتفاهم هسه هذا بارت اوف سكافويد
Okay.
وليش هيك طالع وحده؟ واي اتس جست جوينج الون صارح
Previous fracture مثلا أو trauma.
اوكي
The avascular necrosis.
resulting in avascular necrosis وين الفراكشر؟ where is the fracture?
This is the line.
This is the fracture line at the waist of the scaphoid making it
In,
two parts
yes,
two
avascular
bones
and
okay
avascular necrosis.
resulting in suspected avascular where is the avascular necrosis in which part in this part or in this part which part is avascularized the proximal or distal
The more susceptible is the proximal.
is the proximal
Because it comes from distal to
good
proximal.
because blood supply comes from distal to
Yes.
proximal
So proximal is
to
more-
confirm that you can see this part looks normal on T1 and T2
Yes.
while this part looks hyper intense and if you go to
Why on the step both they are highlighted?
sorry
On the step facade they are both highlighted.
they are both highlighted indicating that this part is still not dead دي edema بعد so the whole purpose of the image is to see do we make a screwing حتى يزيد the blood supply to increase the blood supply to the proximal fragment or it's dead game over when there is edema here means this bone is still viable it's not completely dead maybe they can save it they open they put a screw inside screwing مثل ما يسوون بالفيمورال AVN يحطون screwing first حتى increase the blood supply in order to preserve as much as possible so this is just typical scaphoid fracture typical يعني هذا ماكو غير يعني more typical than this it won't be
يعني كتقريب ما راح نكتب avascular necrosis.
there is a fracture at the waist of the scaphoid associated with bone marrow edema at the proximal and distal fragment suggesting يعني endangered or impending avascular necrosis impending if you leave it it will go into fully necrotized bone fully dead bone okay so they can hurry up and make something before it goes dead okay
History chronic.
no I didn't say chronic I said few months
3 months.
إيه؟ يعني مخه ما ادري ديد بعد باكر راح يصير ديد اوكي
Next time.
needs time to go into fully devascularized bone okay any questions thank you